Good morning, everyone. This is Patricia from the International Hospital Federation. Thank you for joining us today. I would now like to introduce the Chair of HealthCareCAN and President and CEO of Hamilton Health Sciences, Rob McIsaac, to say a few words.
Yeah, thanks very much, and good morning, everybody. Well, everybody from Canada, good afternoon to all of those joining us from Europe. As just noted, I'm Rob McIsaac. I'm President of Hamilton Health Sciences. And I also have the great honor of being chair of the board of directors of HealthCareCAN. I'd like to thank everybody for taking time out of their busy schedules to join us today and to welcome you to this joint webinar with the International Hospital Federation. You know, the past months have been challenging for all of us, to say the least. COVID-19 has left no country untouched, and many health systems around the world have been pushed to their limits under the pressures of the pandemic. We've all had to contend with scarce resources. You know, many of our critical research activities have been stalled. Medical procedures have been postponed. And we've had an overburdened, overstressed, and exhausted workforce. I just want to commend all of you for all of your efforts. And I think we can all take some pride in the fraternity that we share in this regard. It seems that finally this incredible show of resilience has started to pay off, and we're starting to see curves slowly flatten in many countries, and many are starting to think about next steps. As Canada prepares to reopen, health leaders have been tasked with restarting the health system. But what does that look like? And how do we do that in a way that is safe and effective? This webinar is sponsored by HealthCareCAN in coordination with the International Hospital Federation. Will provide international and Canadian perspectives and insights to help guide people through this process. I'm pleased to welcome today our European friends and colleagues, looking forward to hearing them share their experiences and lessons learned in restarting services, managing the backlog of care, addressing health human resource issues, and gaining insights on how to best prepare for what we all hope will not happen, a second wave. Following each presentation, we'll open the floor to pre-selected Canadian representatives from within HealthCareCAN's membership to ask questions, and hopefully we'll see some good exchanges as a result of that. Dr. Pierre Feller, President and CEO of McGill University Health Centre in Montreal, Quebec. Kevin Smith, President and CEO of the University Health Network in Toronto, Ontario. Dr. Owen Heisler, Chief Medical Officer for Covenant Health in Edmonton, Alberta, and Dr. Amy Hsu from Bruyere Long-Term Care Organization. My thanks to all of you for speaking and providing Canadian perspective from your regions within our country here in Canada. If there is time remaining, we encourage all webinar participants to take full advantage of this opportunity to ask questions of your own. For those that were unable to join us today, we will publish a recording of this webinar over the next couple of days by request. So without further ado, I will pass the floor to Eric de Rudenbeck, CEO of the International Hospital Federation, who will be facilitating this webinar. Eric, over to you, and thank you very much for this partnership.
So thank you very much, and it's really a great honor and pleasure for us to join the Canadians and the HealthCareCAN for this webinar that we'll try to build up as a conversation. So you was kind enough to introduce all the Canadian speakers. I will introduce the European speakers that will be on board with us, and we'll roll out our webinars through 4 moments, if I can say, each of them dedicated to a specific topic, for which we'll have an introductory presentation, additional comments, the perspective and questions from Canada, and I guess, you know, with short limited time, with the limited time we have, we'll move on. But please do not hesitate to raise questions. Use the chat function. because what we will make sure is that after the webinar, we will ask all the panelists to answer to your questions, and we'll come back to you with written answers to all your questions. So don't be shy in asking questions, and don't be frustrated if you don't have immediate response, but you will get a response to your questions. So the panelists that we have from Europe are the following, and the first one who will be speaking is Cédric Lussiez, who is the CEO of a hospital in the Greater Parisian region, and he will cover the question of the human resources. We'll after have Dr. Helmut Kern, who is leading a number of, sitting in the boards, a number of companies in Vienna, Austria, and he will also bring the experience from a large private non-for-profit hospital from Vienna. And we have the third panelist, Dr. Jordi Saltes, who is from Plateau Hospital, a also large private, a foundation hospital from Barcelona, Catalonia, Spain, who will bring us to the new normal before we finish with Amy Su on the very specific but challenging aspect related to long-term care. So let's start with Cédric. The floor is yours, and I will be running after your conversation to the other European panelists and give the floor to the Canadian panelists. Cédric, please.
Thank you, Eric. I'm very honored and privileged to stand for France in this webinar and to give you some insights on what's going on here. My first words would be to remind us that we all faced, of course, a heavy crisis, but for France, the death toll is very high with 29,000 deaths. And in the Paris metropolitan area, where my 3 hospitals are standing, it's about 10,000 deaths that we have been suffering. So the situation in the early weeks of March and April was almost like a nightmare. Despite this nightmare, the human resource mobilization has been very easy, incredibly easy. I would never have thought that we could have overcome the crisis in this way. To give you some general information, in my hospitals, I have 3,000 staff. Half of my staff changed its job in 1 week. We have tripled, of course, the number of intensive care beds, created a number of units, and it was very easy because a lot of physicians outside the hospital, a lot of nurses outside came to join and volunteer. I was able to hire in 10 days about 70 nurses, extra nurses, and 20 physicians more. And every day I had to, of course, cope with the epidemic, with the surge of the epidemics, but also with the people who were volunteering inside the hospital. We stopped almost 95% of the surgery. And for instance, my surgeons, they were unemployed, and they volunteer to move people in the intensive care units. I mean, on a basic job, but they wanted to make something that would make a difference. My trade unions, they have some staff who are devoted 100% to their trade union organization, and they stopped their mandate and they volunteer to help and to create new units for COVID-19 patients. So it was very impressive from my point of view, because this first wave time was a time of tragedy sometimes, but a very positive time for any people who were there, because most of the energy that we use for internal conflicts and disagreements was used only for the patients with one single aim, which was to save lives. So the human resource mobilization was very, very easy. The most difficult thing for us was about the qualification of nurses in the intensive care units, where we had to train the nurses with a qualified nurse helping a general nurse from the surgery or medicine unit to prevent any failure in the treatments that we deliver. This time is sadly over. The epidemic in France is almost under control for 6 or 7 weeks now. We are still, of course, fearing a second wave in the autumn and winter. But what we are facing now is something like a backlash, which is that the return to normal life in our hospitals is very, very difficult. Not only because of social distancing and any protocols that we have implemented to prevent new contaminations. Well, that's logical. But because of the epidemic, many people are questioning the way we were delivering care before, the standards of productivity that we urge, especially nurses, to respect. And I've got every day new demands to, I would say, give more humanity to our organization and to increase, for instance, the number of nurses or physicians per patient, outpatient or inpatient. And this is very difficult for us because we were very used to a crisis period on a very short term, and now we are at a national level, of course, because there are some negotiations that the government is having with the unions at the national level to increase wages and things like that for the health professionals. But what is very difficult for us is that this demand is at a very basic level in any health unit. I mean, everyone is saying, hey, we won't come back to the world, to the pre-COVID world. So the human resource mobilization, which was very, very easy from my point of view in April, has been dramatically difficult for weeks now. And even before this likely second wave, we are trying to find a new way of balancing the needs of our staff and the number of patients who of course came back, especially from chronic disease patients, in mental health patients also, with a big crisis right now in France. And I really don't know exactly how to handle with these issues, because we did not change our economic model, I mean, for hospitals. And we clearly have to asking the government help to set a new framework to understand these demands. Maybe I think it's better if I'm taking some questions.
Okay, thank you very much, Cédric, showing clearly, you know, during the crisis, everybody mobilized, but after the crisis, it's very difficult to manage. Any comments from Jody or Helmut in relation to that, on how you have been managing in your respective hospital the post-crisis and the demand that is coming from outside of the crisis, before we move to Pierre, who will bring this perspective with the experience from McGill?
I think I'm fine. From a European perspective, there's nothing more to cover from Vienna here.
Jody, nothing?
Yes, from Barcelona, the situation is very, very, very similar as described for Paris. the mobilization of human resources was easy in this first wave, but the problem will be in the next wave. No, I think that it's not easy, not so easy. The key is the multidisciplinary teamwork. I think has been seen as only way to act in a coordinated and efficient manner. And this must follow, no? Intensivists, anesthesiologists, internists, surgeons, all together in COVID units, in emergency rooms, have worked together to preventing infection, to save lives. No? And I think that is the key for the future new waves. But we also have a shortage of nurses, specialist nurses in intensive care is a problem. Not only the critical beds, no, is the nurses that can care with critical patients is my opinion. Is our point.
Okay, yeah, thank you very much. Breaking the silo, multidisciplinary, and still facing the crisis on human resources for health, which has been a ongoing crisis in most of the countries. Pierre from McGill and Canada, what's your insights and questions?
Good morning, everyone. Good afternoon for those of us who are in Europe. Merci beaucoup, Cédric, pour votre présentation. Quebec was the epicenter of the epidemic in Canada. And when we say Quebec, it's basically Montreal and its suburbs. For a population of 8.8 million people, the death toll is 5,600 deaths, which is 2/3 of the Canadian deaths, whereas Quebec represents only 23% of the Canadian population. 90% of these deaths occurred in nursing homes and long-term care facilities. And I'm sure Dr. Xu will be covering this topic a bit later. So the question, how did we mobilize our human resources? It started very well for the first month in March, but then we lost control in April. I'll get back to that. There was a severe shortage of manpower before the pandemic for two specific reasons. The Canadian economy and the Quebec economy has been very strong over the last few years. So there's been a lot of money injected in the system, new positions opened. So we were already very short on manpower in Quebec and in Canada in general, but more particularly in Quebec. And so we began the pandemic in a difficult situation. In March, with the beginning of the pandemic, we did quite well. But then after that, in April, we really lost control. We think that some of the reasons we lost control was that we have a context in Quebec, which is a bit particular compared to the rest of Canada. Many workers, healthcare workers, are part-time workers. Many of them work in more than one institution. And they could work, for example, 2 days a week in one institution, 2 days a week in another institution in a different service. We also have a lot of personnel who comes from placement agencies, people that come to a hospital or a nursing home in the morning without ever having been there before. And there was also a lot of difficulties in clearly delineating cold, warm, and hot zones, which resulted in a very high rate of contamination of health workers and at least 20 deaths in our healthcare workers. So we lost control in April, and volunteers had to be called in from the general population by our Premier, Monsieur Legault. The Canadian Army was called in to give us a hand, mostly in nursing homes, and the Red Cross as well. So it has been a very ugly story. 2 weeks ago, the Minister of Health was sent to another ministry, and the Deputy Minister was fired. And we have a new team entirely in Quebec in the health and social services system. So I would like to find out from our European friends whether or not similar things happen in any country in Europe.
Yeah, thank you very much. Well, and clearly the topic of compensation, psychological support, and eventually the risk of being suited in relation to the health workers that died are hot topics in various parts of the world. So any of the three panelists have any clue related to that? Please speak in. Cédric?
Yes, we have also a lot of debate on the attitude of the government and the shortage of masks and equipment. About the shortage of nurses, which is a global world problem. The idea that we are trying to implement here in my hospitals is that we need more nurses if we have to increase the number of nurses per patient and the same number of patients. And we, of course, do not have more nurses coming from the universities. So the idea is to find some better conditions of working for nurses so that they stay much more time in the hospital. Currently in France, a nurse is spending about 10 to 11 years in a hospital, and after she resigns, she quits, she works somewhere else. If we are able to give like a second career in a hospital, we hope to have an extra one or second year that would help us to give an answer both to the shortage and to new demands of our staff, and prevent the nightmare that to face a second wave with nurses and health professionals who would not be implied in the answer.
Yeah, so retention of health workforce is a key element, and trying to rethink the scope of the work with more flexibility is certainly a big lesson that we'll all have to learn from with the COVID epidemics and have to put in place. Perhaps from the perspective of Austria or Catalonia, in regard to the psychological support to the staff who had volunteer and has given a lot of energy, time during these tough periods when they had to face the bulk of the epidemics?
Yeah, happy to jump in, Helmut. It's difficult to keep many issues short here in the statement, but to put the COVID crisis in perspective, Austria is about as much inhabitants as Quebec, so we have close to 9 million. We had altogether 580 deaths up till now. But our hospital system is quite different. Austrian, like the German system, is quite oversized actually. So we have a lot of spare capacity. People love to go into hospitals and love to enter hospitals. So we have a high hospitalization rate. And we have many ICU beds. We have 28 ICU beds per 100,000 inhabitants, which is on the upper end of the range worldwide. It's about 3 times what Italy has. And the interesting thing is that on the peak of the COVID crisis, which was end of March, early April, only 10% of our ICU capacity in Austria was used, actually. So that was, we expected that we run out of capacity, but only 10% was on the peak of the crisis. And what happened in the crisis? We felt less shortage of staff than in the non-crisis times, because as the hospitals basically were shut down, we reduced our occupation in the hospital to about 35%, which is the same for all hospitals in Austria. So between 30 and 40% occupation, which means that we closed a lot of the wards and reallocated the nurses. So we implemented interdisciplinary wards, and we had A teams and B teams. Every team working a week on site and a week off site. So in case we had an infection in the team, the whole team would went home and the B team would jump in. And so we did not feel a shortage of resources during the crisis, actually less than we did in the non-crisis times, because we had less patients in our hospitals.
Okay, thank you, Helmut. Pierre, the last word in relation to this topic before we move back to you, Helmut, on the resuming activities.
Yeah, the same thing happened in Quebec. The hospital capacity was never reached. Our blind spot was really long-term care facilities and nursing homes. That's where we lost control.
Okay, thank you very much, Pierre, and certainly many things we could add on this topic. And please use the chat box to raise questions, as we will be very keen to continue the conversation after the webinar. Now let's move to the second point we wanted to address, which is, as we have said, all the capacity has been mobilized to face COVID. That means patients have been put on waiting list. And how do we resume and catch up with the activities? So Helmut, you start, and please, Cédric and Jordi, you follow up before we move to Oven. Helmut?
Yeah, turn the mic on. Okay, here I am. Okay, thanks, Eric. With regard to the processes for restarting, we pretty much very shortly after the shutdown, which happened on 13th of March in Austria, about 2 weeks after the shutdown and changing the whole operations in the hospital, we found out that we got to implement a team to think about how we ramp up services again once the crisis is over. And we thought that's an issue we got to take very quickly and early. And so 2 weeks after the shutdown, we implemented 2 teams which were not too busy with handling COVID. One was called the Restart Task Force, which had to think about how we ramp up the services again, how we plan for handling the patient backlog, how we change our rosters back to normal, and what to keep, which worked in the crisis, and what to change, which did not work in the crisis. We found out during those weeks. And the second team was what we call the cleanup team, because many things have been left behind when we were in crisis mode. And the cleanup team, which mainly was a back office team, took care of all what was left behind, cleaned up mistakes and followed up on problems found during the crisis. Let me just talk quickly about the Restart Task Force. They were thinking and working in 5 dimensions: patients, staff, infrastructure, and then what we called things to keep and things to change. Regarding patients, the main thing was to plan how we reduce the backlog that built up during the crisis. So we had a surgical backlog of operations of 1,500 operations after 8 weeks, and 2,000 additional operations with eyes, cataract operations. We have a pretty big eye clinic. So altogether 3,500 operations which had to be canceled or delayed. And we wanted to plan how to work off that backlog after the first wave. The second thing in the patient's dimension was to extend our day clinic. Austria in general and our hospital as well was pretty much behind in day clinic operations. Countries like Canada are much more advanced there. So we tried to use the crisis to push more operations and more treatments into a day clinic setting. And the third thing with the patients was a very big issue actually, which was how could we handle more patients while maintaining the safety measures in the hospital. So we ramped up about 6 weeks ago now, again, close to normal, but we maintained the entry restrictions with the fiber checks and health checks and COVID checks and all that kind of things. So a big process when you enter into the hospital, and that was quite difficult to find ways to handle more patients while maintaining the safety measures. With regarding the staff, with the crisis, we had to implement new rosters with pretty unusual working rhythms for our staff. And the Restart team had to think about how to go back from crisis rosters back to normal rosters with the interim phase of having rosters to work off the backlog. So we had more working hours in the last weeks and still have them. We work on Saturdays with bigger teams, which we did not used to do. We have regular operations on Saturdays, which did not have in the past. So we have quickly changing rosters, which is a big challenge actually for the team. But actually the buy-in of the people is pretty good there. Also affected is vacation planning, of course, because we need people sometimes on short notice. We need them in times, now is usually vacation time, July and August, so we cannot send everybody on vacation, and vacation planning was a big issue. To prevent staff bottlenecks, which was the next thing. We have in the crisis and then after crisis, we have too many eye surgeons and not enough internal and neurological doctors, for example. And then we had to, with the staff, we had to solve all the legal issues with overtime arrangements, with restrictions for working hours, which are in Austrian and European legislation, which obviously we could not fulfill during the crisis and now after the crisis. On the things to change and things to keep side, we found out actually that interdisciplinary wards work pretty well, and we want to keep interdisciplinary wards, and we do that. And this is something an own workforce, an own team is working on. We have changed our pre-operation process for the patients pretty significantly, made it much leaner than it was, and we want to keep that. We do weekend operations and also weekend pre-operation visits for the patients. We have changes in our outpatient service. We have a pretty big outpatient department with 140,000 outpatient contacts per year. And we had to change the outpatient processes, also mainly due to the increased safety measures. And we also changed our guidelines, the approval process for guidelines. We made it much leaner. For example, in the past, every guideline had to be signed by all the 4 board members, executive board members of the hospital. And now we changed it to 1 clinical and 1 non-clinical board member is sufficient to change a guideline. So we made things leaner, and we implemented home office for a lot of the back office people. And we also investigate if we can continue with that. The things we found out we need to change is occupancy management and bed allocation, which didn't work well in the past and turned out to be working even worse during COVID with interdisciplinary wards. So we changed that process quickly. I talked about the pre-admission, the admission process to operation and pre-surgical process. We changed that. And we also changed our supply management, not only for the crisis, but we found out that we need to extend our base for suppliers. We need to have more framework agreements, and we need to change our stock holding for critical supplies. So that was the restart team mainly, and the cleanup team, as I said, mostly in back office operations. They had to deal with coding errors. They had to deal with documentation, especially in the clinical area, but also documentation in the expenses area. We had to create COVID accounts and allocate expenses to the COVID accounts because we can get them reimbursed from the government. So many things to clean up, which were not taken care of enough during the crisis. We had got to clean up a couple of labor law issues, and we tried really to treat our people well, but still there were some things which were against labor law, against labor contracts. We have to clean that up. And we have a hiring backlog because we had not a hiring freeze, but it was very difficult to hire, especially nurses during the crisis. So we got to work down our hiring backlog. And also the maintenance things and basic purification was not done in the way we planned it actually for the past couple of weeks. So all the maintenance of our equipment has to catch up to get back to normal. Altogether, we all in the hospital don't like the word new normal. Actually, really, we pretty much like the old normal, and our intent is to go back to a better old normal and not to a new normal. What we learned, and I'm closing now with our key learnings, is during the crisis, and that will also be applicable for the second wave, which is coming. We feel it coming in Austria now. Infections are increasing pretty strongly in the last couple of days. The learnings are that speed beats perfection. We couldn't afford to wait till we know things work or things are perfect. We had to implement things very quickly, and we tried to continue with speed beating perfection. We found out that leadership is of the essence in the whole process, and we also tried to continue with that. A big thing to keep the people together, and that ties into the human side Cédric mentioned before, is that we learned that even more we have to be decisive but not divisive. So at one point you got to take a decision, but you still got to keep the people not happy with the decision in the boat. And the biggest learning actually that was that if you take care of your staff, then the staff really takes care of all the rest. So we delegated a lot of accountability and responsibility to lower levels in the management and in the operational teams. And we were, the management team was really rewarded for doing that, because people took the responsibility and just went on. And so they really took care about the whole thing working, and we just enabled them to do the right things.
Yeah, thank you, Helmut. And it's very impressive all that has been put in place, and how transformation happened in a speed that I think nobody would have thought of, as we know how difficult it is to transform in the hospitals. Let's go and see in Canada. Owen, can you bring in your perspectives and your questions from your point of view and what is happening in Canada?
Yeah, so thank you very much. The presentation was very interesting and timely for us. As was pointed out, Quebec took the brunt of the challenges in Canada. We've had fewer deaths than in Quebec. But what appears to us is happening is we had a big initial wave, and now we've got, instead of a second big wave coming on, we've got little bumps at that point, which are facing us at this time. And it's how do you manage that? We're not into the cleanup yet because we're in the middle of that. I really like the suggestion that speed beats perfection. As was pointed out in Quebec, we do have some labor issues with the government coming in, and the government just before this event ripped up the agreement with the physicians in the province and said, we're not going to do that anymore. In addition to that, they told the nurses that they were going to renegotiate that. So we went into the crisis with tremendously poor relationships between the government and the unions. And this has made huge challenges for us in terms of the engagement with the staff going forward. The bed allocation and the occupancy management has been an important thing that we did have in place. I noticed that that was a change that was proposed as a go forward as well. My question would be, the cleanup is going to come to us in the next little while, as Helmut has pointed out. If all those things to do about cleaning up areas and going things, now that you know all the cleanup you have to do, what advice would you give to us that we could prevent that much cleanup when that time's going to come? So I like your advice about what the cleanup is, but what would you have done different so that that cleanup would have been less of a challenge? But thanks for a great presentation.
Thank you. So Helmut or any other wants to come in on the cleanup, because I guess also the situation was the same in Catalonia and in France.
Well, I'll give a quick response from Austria before the colleagues jump in. We would have put more attention on the back office team. So we sent them on home office, and they did a great job working from home. but we would have brought them in back to the hospital earlier to deal with that coding stuff and all the other stuff just on the side. So we would have gained 2, 3, 4 weeks maybe if we had attacked that problem earlier.
So clearly, I mean, if we have to face the clinical urgencies, it doesn't mean that we should drop and put aside all what is the back office and the administration. Any key messages or lessons, Cédric or Jordi, before we move to the situation where I think most of us are? That means we are concerned about a potential second wave while we have trying to catch up with the backlog.
Well, in France, we share most of the comments because, of course, we had some good opportunities to change things, to review cases in order to set priorities for surgery in a multidisciplinary approach, to move to pre-admission, to set day clinics standards. So it was very useful. I would just want to put an emphasis on mental health because this this period has been very hard to stand for many patients. And currently, our emergency rooms are full of psychiatric problems and issues. So our back office in June was to set teams at home and to ask for patients that we did not see, that we didn't have seen for weeks, in order to take them back in their treatments. And just another comment from my point of view is that we are before our new facility in 3 years from now. The COVID has been an opportunity to move to a single bedrooms, which was not the case before. So we cut 25% of our capacity in order to have a single bedroom policy, which is of course very useful, and we can of course go back.
Thank you, Cédric and Jordi, and that will be a transition to the next topic that you will take forward. How did you do with the backlog in Catalonia? Did you have the feeling that, you know, a number of patients that mostly were chronic patients that were not followed during this crisis, well, didn't really come back, and that a portion of the healthcare was not delivered, but without any visible consequence so far? Or are they, like for the psychiatric care, some potential major consequences further to come?
Yes, our experiences is we are very worried about patients with patients with cancer or with heart disease that came to us in a more advanced situation is very usual. And also we detected that many patients in Spain, where the COVID is especially hard, many patients had fear to go to hospital. No? And this is a psychological problem that is not infrequent. It's frequent that, and is a problem that we must manage. Is a new normal, but it's not normal. It's abnormal. No, patient has fear to go to hospital. Is in our experience now.
So these are the key elements. Now we move to the risk of the second wave, for which, while we have to face all these transformations and difficulties with the first wave, hospitals have to get prepared too. So Dr. Altes, Jordi, the floor is yours. I think you have slides to show.
Yes, I would like to share my screen. Yeah?
Good, go ahead.
Okay. the third question is how we are preparing to face the future waves. Spain is one of the countries that have been more affected by COVID-19. More than 250,000 cases and 28,000 deaths. No? But, however, no, we see according to this recent study, you can see that only 5.2% of the Spanish population has IgG antibodies against SARS-CoV-2. And in Catalonia, my region, the seroprevalence is similar. This is the evolution during the worst days of COVID crisis. Critical bed occupation rooms in Catalonia rised more than 2 times our bed capacity here in April. Now numbers are much better. Only 40 patients yesterday. In all Catalonia is 7 million people. Here's my hospital. My hospital is integrated in an area called Left Barcelona with 500,000 residents, is 35% of Barcelona population. And we are working together with Hospital Clinic in Barcelona. Is the first hospital in Barcelona, is the big hospital. Hospital Plateau is a relatively small hospital. And during COVID-19, we have worked together, public and private, against COVID within the area of Barcelona, Left Barcelona. Here is the Hospital Clinic and the 4 hospitals satellite that work together, and that has permitted to give the beds to the critical care and non-critical care. And now some authors draw this pessimistic scenario, no, with recurrent outbreaks and months if a vaccine don't come here in the next month. No? So how are we preparing to that? In Europe, like America, the European CDC is continuously updating documents to adapt healthcare settings, and this is very important. But also at local level, now in Catalonia, have some documents that are very interesting, and the Healthcare Management Society has released 25 proposals from that we have learned. In the next slide, I will remark the 6 proposals that I think more important to face the immediate future, and one more I think is and will be essential, is the next. The first is to promote a much more integrated care, not only hospital, primary care, public health, nursing homes, etc. The second is the multidisciplinary approach. The third is telehealth, telemedicine, and also teleworking. The fourth is public-private collaboration. The fifth is the decrease of low value added activity is very important for the future. The sixth is have a contingency plan for the rapid expansion of critical beds and reorganization. No? And last is more attention to occupational health and training of our healthcare professionals. My last advice is that we must take good care of our health worker. It's very, very, very important. So thank you. It's a photo of a part of our team in the peak of the COVID crisis. No, thank you from Barcelona to Quebec. Thank you.
Thank you, Dr. Altes, and interesting insights on how, at the same time, you have lessons from the first crisis and transformation that should help you to face potentially the worst case scenario that you showed on the screen with repetitive crises. What are the insights from Canada? Kevin Smith from the University Health Network Toronto, if you want to take the floor.
Thank you very much. Thanks for the presentation from Catalonia. Many similarities. So I think clearly, obviously, getting back to normal or whatever normal might look like, we are a bit challenged because our old normal was operating at about 110 to 115% occupancy. That isn't where we wish to return to, nor should it be when we think about social distancing. One of our greatest challenges, I think, has been really rethinking where and how we deliver care. And one of the good things that's happened in Canada, in my opinion, has been bringing a lot more physicians and patients onto virtual care. So at University Health Network, which is made up of a group of hospitals and other healthcare facilities, we saw over 900 doctors come on virtual care models and using some common platforms and backbones. And quite frankly, our biggest challenge will be to ensure that we don't slip back into a model where people wish to return for the ease of the provider, not the ease of the consumer. Secondly, for us, one of the issues that hasn't come up today, we're Canada's largest educational training site. And in the middle of all this, we dramatically interrupted training, as you can imagine, and now figuring out how we actually catch up on our training of physician trainees, nurse trainees, many international fellows, and of course the research enterprise, which was also shut down during this period of time for the most part, and restarting research has also been a very, very important and at times challenging initiative, and I think one of the ones that we have to struggle with more ambitiously, particularly as we know that research will be an important part of solving this crisis. Thirdly, I can't comment on this topic without mentioning we do live next to a border that is closed at the moment with the United States, which is the epicenter of the disease and at the moment. And we're very concerned about how does one prepare for wave 2 when those decisions are well beyond even the provincial government. It's at a federal government level. We also had very spotty disease prevalence. So we really, after the initial wave, had a pandemic, well, a tale of two pandemics, one in the communities, which were reasonably well managed, and as we've heard from others, the one that really had horrible morbidity and mortality in long-term care, which for us meant going to those patients. So we made a conscious choice of, rather than seeing frail elderly people moved into hospitals, that we would actually deploy hospital staff to those environments. And I think now we are stronger, but in no way, shape, or form truly ready for quote unquote wave 2 in long-term care. We need to do a lot more work on readying long-term care. And I think that means likely some ongoing relationship with hospitals, at least as it relates to infection prevention and control, occupational health, PPE supply, and adequate availability of clinicians to manage patients in place, including virtual care. We also ended up now with really two pandemics that are left, and they are in Toronto and Montreal. So the restart in Canada is quite different. In many parts of the province or country, restart started much, much earlier. In one of the academic centers, Kingston, Ontario, for example, I believe before a recent outbreak due to a nail salon, they'd had 1 or 2 admissions. While at the hospitals that I work in, we had a maximum 100 admissions, many of them in our ICUs. So I think, again, the generalization here will have to be regional as opposed to national or even provincial. For me, perhaps the question is, one of the things that we saw that didn't work as well as we might have hoped historically was the divide between public health, epidemiology, infectious disease, and more broadly, public policymakers and government. And the confusion was palpable and continues to be palpable. With at the one end of the spectrum, do the minimum required, so provide minimum personal protective equipment like surgical masks. At the other end of the spectrum, our staff, frightened as we heard from Helmut and others, give me more, I'd like a belt and suspenders model. The evidence evolved, and obviously our position has shifted. That has challenged us and our staff feeling like we're adequately protecting them. So I'd love to hear whether or not that was an issue in your environments, and whether in wave 2, you would be, with a better supply chain, more inclined to give people additional PPE, maybe even PPE that isn't necessarily scientifically indicated, but is emotionally desired.
Okay, thank you very much. And I think you cover many topics that would require follow-up questions, but perhaps the one on the PPE, which has been really a bottleneck all over the world. Perhaps from the 3 Europeans where PPE has been a major issue, are you ready for the second wave? And that will not be anymore an issue, including with new protocols, with downgraded the norms of utilizations of PPEs that were in place before the COVID. Cédric, I know you had a lot of issues in France. Are you ready now to face a big second wave without any concern on PPE? Same for you, Jody and Helmut?
Yes, I think we are ready for a second wave because we have stocks for major PPE, and we are also, self-confident. One of the issues in March was not only the number and the protocols, but also the confidence in what was said by the government. So currently, I think we are able to face a second wave much better than we had to do in the first one.
Is it the same thing for you, Helmut?
I just answered the question on that. Actually, we ran short of PPE, especially of the N95 masks, when the crisis really came in and we started having infections with our staff. Fortunately, we got supply then. What we found out is that the offers, especially of the N95 masks, the quality was not, our quality standards were not met, and there was a lot of bad material supplied. So we used the time now to increase, to rethink and recalculate the stock, and we increased our PPE equipment stock for a 3-month full crisis equipment for the staff. So I think in a second wave, we are fine with our PPE.
Okay, and I guess Jody is the same thing for you, and we'll move after to the last comments on the aged frail population.
Yes, in front of a second wave, we are much better than the first wave. I think that it will be not a problem, no?
Yeah. Okay, so definitely here lesson learned and improvement, which is at least a good thing. Let's move to Amy on the very critical issue of the frail and aged population, and especially in long-term care. Amy, can you share with us what the major issues that you had to face and the questions that are still pending?
Perfect. Thank you, Eric. I'm cognizant of time, but thank you so much it's an honor to represent the long-term care sector in this panel discussion. And the key point that I want to bring up, as Pierre had pointed out earlier, that shortage of staffing in long-term care has been an ongoing issue. It existed prior to the pandemic. We continue to deal with it to an extent that the situation was so dire that the Canadian Armed Forces had to be brought in to support long-term care homes in Ontario and Quebec who had challenges managing and containing the viral spread on their own. And we also know that with the evidence coming out of the first wave of the pandemic, that healthcare worker movement is intrinsically tied to the outcomes in the cases that we see in long-term care. And as a result, the provincial governments in April have all enacted new legislation under their Emergency Response Act to limit employment of long-term care workers to a single facility or a single site within a provider organization. So as you can imagine, this is problematic in an environment where there's already staffing shortage and where up to 20% of the workforce actually has a second job, either working at another long-term care home or in a hospital. And so the long-term care sector in Canada, many parts of Canada, had to rely on that collaboration that Kevin mentioned earlier with acute care sector, with hospitals and also community care providers in order to supplement the workforce. Now, these temporary measures have worked out well in terms of health human resource mobilization, but these are temporary solutions and not viable long-term solutions. So as you can imagine, healthcare workforce stabilization is an important aspect in terms of how we think about or how we plan for the ongoing situation with COVID, how the long-term care sector could work closely and maintain a partnership with the acute care sectors and hospital. And, you know, coming back to the point in Barcelona or in Spain, how do we support integrated care in this new environment? So my question is, I'm looking to the experience of other countries in terms of whether these partnerships have been established in the pandemic and how they can, how they sort of envision or could recommend we maintain these relationships and partnership and to support integrated care between long-term care and hospitals.
Anyone want to come in and perhaps, and very quickly because we need to wrap up, but in relation to that, because we are talking about infections, how much maintaining more the aged people at home has benefited from an additional support with hospital at home or long-term care at home, and what's the role of the hospital versus dedicated services and organizations? I don't know, perhaps Cédric, where you have, I know in the Paris region, a famous organization called Santé Service, who is doing all this home care for the aged population and those that needs that can avoid to go to the hospital.
No, unfortunately, we didn't. We had a poor relationship in the epidemics because of the shortage, and we did not have a death toll very high death toll in the institutions that were strongly connected to hospitals, because we were able to send some professionals. But in some of the private for-profit institutions, there were a lot of people who died without because there was not enough PPE, not enough staff. So I mean, we had a situation that was sometimes much more like in Quebec. I mean, so I think in the second wave we are urged by the government to set these partnerships that Amy is asking, but currently we did not perform well.
So this is still a major pending issue that is not yet solved, and that's going to be facing us if we don't react quickly. Helmut, in Austria, because also you have quite an aged population.
Yeah, I was just answering an answer here on the thing on equity. What we found is that the COVID was over everything else, right? And so we didn't have less access to hospitals by social differentiation, but we had a lot of treatments and a lot of endoscopy, for example, or preventive treatments not having been done due to closed hospitals. And so we would expect a higher death toll for cancer, for example, non-detected cancer, which now will be detected in too late stages. We will find many problems with other illnesses coming up in the next couple of months. With the aging population, it's hard to find out if there is statistical prevalence with age groups or not. It's too early to say that now.
Okay, and Jody, a last comment before we hand over the floor to Paul-Émile Cloutier, who is closing our webinar.
Yes, in Barcelona, the COVID crisis is a nursing homes crisis, really. 10% of residents in nursing homes have died, 10%. And this now is different. The health system has included nursing homes as health institutions because they are full of chronic patients, no? And we are preparing for a second wave, and I hope that it will be very different, very different in PPE and PPE, in nurses, geriatric nurses, no, in doctors, and now we are making efforts to do this, to prepare for a second wave that don't affect to our people, our elder people. Mm-hmm.
Yeah, thank you. And so, in a nutshell, really, it's about and I'm going to talk franglais. The medicalization of old age structure is a key element to face the second wave and to avoid the disaster that we have seen in many countries with nursing homes. Thank you to all the panelists, and I give the floor to Paul-Émile Cloutier, the CEO of HealthCareCAN, who will have the difficult task to wrap up our conversations that were very rich, touching many subjects, and hopefully helpful for those who have participated and attended. Paul-Émile?
I think, as you said, it was an extraordinarily rich conversation, and I'm really grateful for all of our participants who participated today. I think it's safe to say that nowhere has the impact of the pandemic been felt more strongly than in the health system worldwide. And I think many countries are reviewing their healthcare system as to whether if it is responsive to patient care. It has completely changed the way hospitals operate, from how care is delivered and how administrators must manage the flow of patients and the physical and mental health of your workforce. With the second wave of the pandemic expected in the fall, or maybe earlier in Europe, the decisions that health system leaders will make today and in the coming months, in my view, are the most important decision to be made in the generation. Je remercie tous les participants, our friends and our colleagues from Europe, and also our Canadian colleagues who participated in this. I felt it extremely insightful, and I think there's a lot of material there that will help many other stakeholders who either participated or are not part of our conversation, that they will find it very insightful. So I hope that this HealthCareCAN sponsored webinar in cooperation with our friends at the IHF has been very valuable, and help you to provide some guidance and insight for you to consider in the resumption of the services. And I wish you all well and be safe and continue the good work that you're doing. Thank you very much.
Thank you very much, Paul-Emile, and to all our panelists who joined us today. Thank you so much for all the insights that you've shared. Just a reminder to all our participants, the recording of this webinar will be sent to you via email in a few days. And we'll also email you the responses of our panelists to the questions that you sent. In the meantime, you can go to our website to watch recordings of our past webinars online. In the last few months, we featured experiences of various hospitals and how they managed their response to COVID-19. And you can watch them on demand at your convenience. Just go to www.ihf-fih.org/webinar. So thank you again for joining us today. I hope you all have a lovely day ahead of you. Stay safe and healthy. And we hope to see you again in our future webinars. Thank you, everyone.
Thank you.
Thank you, everyone. Merci beaucoup. C'était un plaisir. And we'll hope that we can continue on other opportunities. Stay safe and take care. Goodbye.
Wow.
Thank you. Bye.
Au revoir.